Hi, good afternoon, everyone. My name is Dr. Dominic Akatiba. I work with Ghana Medical Help. Thank you for joining us for this week's Community Service Agenda webinar. This week, we are looking at human immune deficiency virus, otherwise called HIV. Most of us in clinical practice would have encountered a patient or the other with this condition. And over the period of time, we know that following the WHO guidelines and the Ghana local guidelines, there have been a couple of updates in the management of HIV. So it's time that we look at those since our last webinar about a year ago on the same topic. To help us do that today, Dr. Kobna Opon Chairman is a resident physician and specialist in training at the Kolebu Teaching Hospital. Dr. Opon works with us as well at the Upper West Regional Hospital, where he's currently in training. We are grateful that you join us for this webinar today, and just a few rules for you to take note of. You'll be unable to unmute yourself. However, the chat box is open and available. Kindly make use of it in case you have a comment, a question, a suggestion to make whilst the presentation is ongoing, so that in about 30-45 minutes, we'll have a discussion around these. Today is World Kidney Day, and we wish all those in nephrology and in managing patients with kidney diseases a happy celebration as well as advocacy about kidney and kidney issues. We encourage all practitioners, especially those of us in rural environment where it's quite warm and hot, to take in a lot of water, get your kidneys checked, make sure that, like the theme of this year goes, that your kidney is okay. So just to also highlight that there's a webinar by the Ghana Kidney Association also ongoing. I think it starts at 3 o'clock, as well as a series of other webinars. So I'm sure a lot of people may be joining several other webinars as well. Good enough, we are recording this webinar, so we'll put it on our YouTube page so that those who probably are involved in the Ghana Kidney Association webinar or any of the other webinars that have been scheduled to mark the World Kidney Day will be able to. Kindly join me in welcoming Dr. Opon to lead us with the presentation. Dr. Opon, your participants are waiting for you. Thank you. Kindly unmute yourself, Dr. Opon, and then you can start. Dr. Opon, can you hear me? Kindly unmute yourself.
Yeah. So good afternoon.
Good afternoon.
I think my boss has done very much well with the introduction, so I don't need any more introduction. So this afternoon, I'm going to take you through HIV, which is a very common condition worldwide. We'll look at some changes in their modalities of treatment. So this is the outline of my presentation. We will first look at some introduction, epidemiology, pathogenesis of the HIV virus, some clinical presentation, and then we look at the diagnosis and management of HIV. So HIV is actually an infection which is caused by the human immunodeficiency virus. This virus specifically attacks white cell, CD4 T cell lymphocytes of the white cells. And usually when humans are affected, the body becomes immunocompromised, and therefore other infections can then set in. If this virus is untreated, it leads to what we call AIDS, that's acquired immunodeficiency syndrome. Now, once someone gets infected with HIV and then AIDS, we say it is AIDS when the CD4 cell count is less than 200 cells per millimeter cube. And the normal CD4 cell count we have in our system is between 500 and 1,000 500 cells. So once you get AIDS, it means that your CD4 cell count has been dropped down to less than 200 cells. Now, we look at some epidemiology of HIV, and worldwide, WHO estimated close to 40 million people living with HIV in the year 2023. So close to 40 million people were living with HIV in the year 2023. And out of this, we recorded death, or WHO recorded death, estimated death of about 630,000. And that's huge for just one condition to cause such great havoc. Over 630,000 deaths were recorded in 2023 alone. Coming down to Ghana, Ghana AIDS Commission in 2023 recorded a total number of 334,095 people living with HIV/AIDS in Ghana. And out of this, close to 12,500 died. These were recorded values. So you can imagine people who have HIV and we did not even test or did not know them. In 2023 in Ghana, we also recorded new infections of HIV recorded was 17,774, and that's a lot. Close to 18,000 new infections was recorded in Ghana. And this source is from WHO and Ghana AIDS Commission. Let's look at the pathogenesis of this virus, HIV. It belongs to a family we call Retroviridae, and then the genus is lentivirus. Okay, this group of viruses, we have two species. We have HIV-1 and then HIV-2. We will come to that. And the structure of HIV virus has an icosahedral symmetry. And when we say this, it's a kind of virus that has like polyhedron kind of structure. It's like the football we play. Okay, so the structure of HIV is complex and is the same as the structure of hepatitis B, poliovirus, and other virus, herpes virus, all have icosahedral symmetry. And this symmetry is connected with a conical capsid and a spiked envelope. And that's the picture I have put here. The genome of this virus contains some pseudodiploid molecules, and these pseudodiploid molecules have 2 RNA and then 1 DNA, and then it contains 9 genes which code for a total of 15 proteins. Now, some functions of these structural proteins, I want us to take note of the POL gene that codes for these 3 important proteins. The protease, which is a GAG and then GAG-POL proteins during maturation of the viron. And then the reverse transcriptase is an important protein that converts the viral RNA into the double-stranded DNA. You know, humans are made up of DNA, but this virus has an RNA, but when it enters the host cells, it converts itself into a double-stranded DNA, and that is done by reverse transcriptase. There's also another POL gene we call the integrase, and this integrase helps the HIV virus to enter the host genome. That is the work of the protein integrase. There are other proteins. We have the ENV protein, we have the GAG protein, and we also have the REV gene. The ENV gene also is very important because it has some glycoproteins that helps this virus to attach to the host T cells. That's the lymphocytes of the host cells. So that's the work of the glycoprotein 120. It helps the HIV virus to attach itself to the host CD4 T cells. And then GP41 assists in fusion and then entry of the virus into the host cell. There are other genes, as I said, TAG gene and then the REV gene. Now, the 2 main species or types of HIV we have. Worldwide, HIV-1 is the most common virus we have, HIV-1. But time on after 1981, when HIV was discovered, scientists realized that there's another type that was common only in West Africa. That was way back in the 80s, only in West Africa. That is HIV2. It was found in West Africa, but now it's gaining grounds in the India, Europe, and then USA. But in Ghana, though West Africa, HIV2 is common, in West Africa, HIV1 is still the commonest type. So those of us who are still students in exams, which is very common in our MCQs, HIV in West Africa, HIV1 is still the commonest, but we still have HIV2, which is also found in West Africa. So this is the structure of the HIV virus. And as I said earlier, the gap GP41 glycoprotein, and then the GP120, where the virus attaches itself to. What are the mode of transmission or the routes of transmission? I categorize this into three main types. We have the sexual route, we have the parenteral transmission or the parenteral route, and then the vertical route. Now, the most common worldwide is through sex. So once there is unprotected sex, the person is putting his or her life at risk of acquiring HIV. So 80% of worldwide infection is through sex. And that is, people get it through unprotected sex or men who have sex with men, and then from male to female intercourse. The parenteral route, as we know, most common that we found in our hospital settings when health workers are incidentally injured by needle prick, or when needle stick injuries happens to healthcare workers. That is a parenteral mode of transmission. Also, people who inject themselves with drugs, okay, injectable drug users, that's also a parenteral transmission. Blood transfusion, usually like 0.01% of parenteral transmission is through blood transfusion. And then also, as Dr. Dominic said, today is World Kidney Day, true patients who undergo dialysis have also a risk of acquiring this disease. So before a patient is put on dialysis, we do viral screening, hepatitis B screening, hepatitis C screening, and then HIV screening to ensure that the patient does not transmit this virus through dialysis to other people. Now, vertical transmission is when mother transmits the virus to the child, and this way is through breastfeeding and then during childbirth, and then also yes, through breastfeeding and then during childbirth. Now we look at the pathogenesis of HIV, and I'll make it very simple for us to understand. The virus, the HIV virus, first enters the host through mucosal break or infection. Okay, and after the virus has entered the host, it binds in the GP120. So the glycoprotein 120 helps the HIV virus to bind to the host cells. Once binding is done, there is what we now fuse to the host cells. And this is done after the fusion. The virus enters the host cells. Once fusion is done, there's transcription. Itself from RNA into a double-stranded DNA, okay? And then once transcription is done, the virus is now integrated into the nucleus of the host DNA, okay? After the transcription, there's integration, and this integration is done in the nucleus of the host DNA. Once integration is done, the virus now, DNA is now replicated, and then it's assembled itself close to the cell membrane. This replication and assembly is done, the virus breaks itself through the cell membrane, and then through a process we call budding, and then the process goes on. It infects other tissues and then the lymph nodes. But with the chronic progression of the HIV virus, what happens is that the HIV infects, like as earlier said, it infects the host CD4 T lymphocytes, okay, cells. So once these cells are infected, the virus reproduces and spreads to other CD4 cells. Okay, it first infects the CD4 cells and it reproduces itself and then affects other CD4 cells. The CD4 cells is now concentrated in specialized lymph nodes, okay, specialized tissues like the lymph nodes. So usually people come and they have a lymphadenopathy. But mind you, not all HIV patients, not all patients that comes with lymphadenopathy have HIV infection. But the virus works its way through the lymph nodes and then also through the gout, that's the gut-associated lymphatic tissues. So once the virus concentrates in these lymphoid tissues, they grow explosively and then disseminate to other tissues. And after that, there's an acute HIV syndrome with high viremia because the virus is now multiplying at a very fast rate. Some clinical features, and you categorize this into 3 stages. We have stage 1, which is the acute HIV infection, and then the chronic stage, which is stage 2, and then we have the AIDS itself, which is stage 3. So stage 1, usually when patients come and then you don't do proper screening, we may equal it to other viral infection, okay? Because patients comes with specific, non-specific symptoms like headache, myalgia, that is muscle aches, fatigue. Patient may present with sore throats. Some may have swollen lymph nodes and then fever. So at stage 1 of the clinical stage, which is also referred to as the acute HIV infection or primary HIV infection, patients come with vague symptoms, okay? Headache, fever, sore throat, swollen lymph nodes. Now, stage 2, which we call the chronic HIV infection, patients may be asymptomatic. Okay, you may not see anything at all, but the virus may be there. And then stage 3, where there is fully blown HIV or fully blown AIDS, that there is swollen lymph nodes at the groin or the neck, as I have shown in this picture. You can see the lymph nodes on this young guy at the neck, around the neck. Okay, and then there's also diarrhea, which spans for about a month. Patient may tell you, I have been having diarrhea for more than a month, and the patient may not know the cause of it. You might have taken a lot of medication, but diarrhea is not resolving. There may be unexplained weight loss, and that could be like sometimes at the beginning, maybe less than 10. As it progresses, it may be more than 10% of weight loss by patients with HIV. And then also fever that lasts more than 10 days. Okay. And of course, there may be some throat or vaginal infection. So basically, this is the presentation of HIV patients categorized into 3 stages: stage 1, stage 2, and then stage 3, each of them with their specific findings. Now, coming to classification of HIV, there are 2 systems I had, and the first one, I'll use the CDC, that's the Center for Disease Control. They categorize HIV infection based on CD4 counts and then current and previously diagnosed HIV-related conditions. And in this staging, CDC says that any patient that has a stage categories A3, B3, and then C1 through to C3 have AIDS. But this is how it is done. We have clinical category A. Patient may be asymptomatic, or patient may have persistent patient may have so patient may have persistent generalized lymphadenopathy or asymptomatic, and then stage 2 or stage clinical category B. Patient may be symptomatic, but may not be either found in category A or category C. Now, CD4 cell count, as I said, the normal one is between 500 to 1,500 cells per millimeter cube. So for CD4 cell counts more than 500, patient may be at category A, which may be A1 or B2. And then CD4 between 200 and then 499, patient may be in category A2 or B2. But CD4 cell counts less than 200, patient may be in A3 and then B3 and then through C1 to C3. So any patient that falls between these and then has less than 200 males of CD4 cell count and then B3 and then also C1 through to C3 has ACE. But those in A1, A2, and then B1 and B2 may not be categorized as patients with ACE. WHO classification is done based on clinical features and then diagnostic findings. Now, this is more specific to the investigations we do, laboratory investigations, and then our clinical findings. So we have primary HIV infection, and then we have clinical stage 1 HIV infection, clinical stage 2, stage 3, and then stage 4. Now, clinical stage 1 or primary HIV infection, there is an acute viral syndrome, or patient may come with no symptoms at all. But stage 1, there's persistent generalized lymphadenopathy. Okay, patient may come and tell you, I have swollen lymph nodes, or I have a swelling in my groin or around my neck. So as a physician or as a medic, you are supposed to do thorough investigation to unveil the cause of this, unravel the cause of this persistent generalized lymphadenopathy. So clinical stage 1, that is the main symptoms patients may present to you according to WHO classification, or the patient may be asymptomatic in all. In stage 2, patients may present with an unexplained weight loss, less than 10%, okay, more than 10%. So patient may be 80, and now come to you and tell you, oh, I have, my weight have reduced. I'm now about 72 or 70. You should think about HIV infection, okay? So unexplained moderate weight loss, less than 10%. And then patient may also come with other vague viral or bacterial infection. In clinical stage 3 of the HIV WHO classification, patient comes with multiple presentation. There may be weight loss, which may be more than 10%. There may be persistent diarrhea, which may be more than a month. Constant diarrhea, which may be more than a month. And then when you do some laboratory investigation, there may be anemia, less than 8. Okay, and then neutropenia usually less than 500, and then thrombocytopenia less than 50,000. Okay, so clinical stage 3, patient present with numerous clinical features. Okay, both in laboratory wise and then clinical findings. Fully blown AIDS or stage 4, patient comes with opportunistic infections such as pneumocystic pneumonia, histoplasmosis, Kaposi sarcoma. So these are the classification based on WHO findings. We have the primary HIV infection, stage 1, stage 2, stage 3, and then stage 4. So we've looked at CDC mode of classification and then the WHO classification of HIV. Now, these conditions are referred to as non-AIDS defining illness. Okay, so the fact that the patient has diarrhea does not mean that diarrhea is an AIDS defining illness. So patient may present with CD4 count less than 500 cells per millimeter cube. And then these symptoms, okay, subfebrile temperature, persistent generalized lymphadenopathy, oral candidiasis. And mind you, oral candidiasis is not an HIV or AIDS defining illness, but then esophageal candidiasis is an AIDS defining illness. So let's take note of these two differences as we practice and then see our patients. So AIDS defining illness now, CD4 cell counts less than 200, patients may present with opportunistic infections such as pneumocystic pneumonia. And then less than 100, usually you may come across esophageal candidiasis, cryptococcal meningitis, cerebral toxoplasmosis. And then as the CD4 cell count decline further to less than 50, there may be disseminated mycobacterium avium complex, and then also cytomegalovirus, which may be rhinitis or colitis. So these conditions are referred to as the AIDS-defining conditions. Now, to diagnosis of HIV, we look at, first, before you diagnose the patient with HIV, patient have to be screened. And once you screen the patient, you now do a confirmatory test. Okay, so screening is done with a fourth generation antibody and antigen assay. This test does two things. First is detecting the P24 antigen in the blood, okay, and then also detects the HIV antibody also in the blood. Now, mind you, if you refer a patient to do ELISA, ELISA only will detect the antibody, but it will not detect the antigen. So ELISA cannot be used as a screening tool for HIV. But you do the fourth generation antibody antigen assay, and that one can detect both the P24 antigen of the virus and then the antibody of the virus. So now, while this is done, and then it comes out to be positive, then now you want to confirm whether the patient have HIV-1 or HIV-2. So to do this confirmatory test, you now do HIV-1, HIV-2, antibody differentiation immunoassay. So this is a confirmatory test for HIV. Once this test is done and it comes out positive, then you can record that the patient has HIV. Patient is positive to HIV. Now, when you do this immunoassay test and then it comes out negative, then on a high suspicion, sometimes the HIV-1, HIV-2 antibody differentiation immunoassay may come out negative with a suspicion that this patient may still have the virus. Now, when this happens, you want to do plasma HIV RNA testing. And RNA testing, you are doing what we call the nucleic acid amplification test, nucleic acid amplification test, or the polymerase chain reaction RNA. Once this test is done and it comes out positive, then you now categorize the patient as having HIV. And very important. So we don't use antibody tests to screen for HIV in infants. And the reason is that during the pregnancy stage, the mother's maternal IgG can cross the placenta and then enters the child's blood. Okay, so when you do an antibody test, it may come out positive, but that doesn't mean that the child is positive to HIV. So what you do is in children is HIV-1 RNA testing. HIV-1 RNA test, and like I said, that is the PCR and then the nucleic acid amplification test. So once you do this test and it comes out positive, then you can say the child has HIV. In Ghana, HIV screening and testing for pregnant women and the general public, there are basically three things we need to learn here. And this diagram, I picked it from Ghana AIDS Commission booklet. So there are three things we need to know from this thing. The first one is first response, and then you do oral quick, and then you do the SD bioline. These are the three things. These are the three important things. So once you do the first response and it comes out negative, patient can be, we can say that the patient is negative to HIV. But once first response is positive, okay, you go ahead to do oral quick. You go ahead to do oral quick. And when oral quick comes out positive, so first response is positive, oral quick is positive, then you now want to confirm by doing the SD bioline. Okay, so when you enter the consulting room, sometimes this thing is pasted there, but you need to take your time. You first do the first response comes out positive, you do the oral quick. Both oral quick and first response are positive. Now you want to confirm, then you do the SD bioline. So once these three, first response, oral quick, and SD bioline all comes out positive, you can now say that the patient is HIV positive. Now, when first response and then oral quick comes out, and then they are all non-reactive. You do SD bioline and also becomes negative or positive. You try and do that, repeat the test in 14 days, that's 2 weeks. Okay, and then on the other hand, once the oral quick and the first response are reactive, but the oral quick, yeah, so once first response and then are reactive, but oral quick is negative, you repeat both first response and then the oral quick subsequently. And once you do it and it comes out now positive, you confirm with SD bioline. Okay, so this table is not so difficult to understand. There are 3 things you need to do: first response, oral quick, and then SD bioline. Now let's come to the treatment of HIV. And before we tackle the treatment of HIV, let's look at the antiretroviral drug mechanism. How does this drug or how does this virus work? So the virus first attaches itself to receptors of the CD4 T cells in our white blood cell count, specifically CCR5 and then CXCR4. These receptors are the receptors that the virus attaches itself to. So once the virus attaches itself to, it now enters the cell membrane. This is the cell membrane. This orange colored here is the cell membrane. The virus enters the cell membrane. And mind you, this virus is an RNA virus. It needs to convert itself to DNA for it to work well in humans. So the RNA of the virus is now converted into DNA using the reverse transcriptase. So that's the first step after the virus has entered the body. It wants to turn itself into a DNA. So it uses the reverse transcriptase to transcribe itself to DNA. And once this is done, the virus now integrates into the cell's nucleus, okay, using the enzyme integrase. So it now integrates itself into the nucleus. And once this is done, copies of the RNA are made and then proteins are made. And then now it's now bad itself out of the cells and then form a new virus. Okay, so this is basically what happens when the virus enters. Now, the mechanism of antiretroviral drugs, we have the non-reverse transcriptase inhibitors. We have the nucleoside reverse transcriptase inhibitors and then the non-nucleoside reverse transcriptase inhibitors. Now, these two antiretroviral medications or drugs inhibits the reverse transcriptase. So as you see here, this orange here means that these drugs are inhibiting this enzyme or protein, reverse transcriptase. And once this is inhibited, the virus cannot do what? Transcribe itself into DNA. And then what does the integrase inhibitors do? The integrase inhibitors of antiretroviral drugs also inhibit integration of DNA into the nucleus. So the virus is now prevented from moving from its DNA into the nucleus of the host cells by these medications or these inhibitors. And then the last portion or the third one, the third proteins or the third enzyme, the protease inhibitors inhibit the proteases. Okay, so this is not difficult to understand. There are 3 main enzymes or proteins: reverse transcriptase, the nucleus, and then the protease. So these 3 medications are tackling these various enzymes or proteins. So these are some of the antiretroviral therapies that we have. Always remember that there are 2 backbone therapies, and that is 2 nucleoside reverse transcriptase inhibitors. So most of the time, the antiretroviral medications we give to our patients is made up of 2 nucleoside reverse transcriptase inhibitors. And these are the backbone of the medication. Now we are having medications coming in that are combined into a single tablet for patients to make it easier for patients to swallow. But the antiretroviral medications that we have, so most of the time when they visit us in the consulting room, after they have visited the HIV clinic, you realize that they are either holding 2 different containers or 3 containers. But mind you, the medication is always made up of two backbone medication, which is two nucleoside reverse transcriptase plus any of the other types. That is the one non-nucleoside reverse transcriptase inhibitors, or two nucleoside reverse transcriptase inhibitors plus one protease inhibitor, or two nucleoside reverse transcriptase inhibitors plus one integrate inhibitor. So these are the two or the three forms of medication that we have. And always remember that there are two, the backbone therapy consists of two nucleoside reverse transcriptase. So according to CDC in 2021, these are some of the medications we have. So two, as I said, two nucleoside reverse transcriptase inhibitors. We have tenofovir and then the emtricitabine. These are nucleoside reverse transcriptase inhibitors medication plus one inhibitor, integrate inhibitor, plus one integrate inhibitor. That is the bictegravir. So these three medications now come in one container or one medicine combined into one medicine, and it's called the bictegravir. So we have bictegravir, which can be taken one tablet per day, and that's a combination of all these three medications, which are two tablets or three tablets at a time. Another combination of antiretroviral medication we have is two nucleoside reverse transcriptase inhibitors plus an integrate inhibitor, and that's abacavir. Normally, this is what we usually see in consulting rooms when patients come to us. I mean, this is what I have mostly seen. Abacavir, which is 600 milligram OD, and then lamivudine, which is 300 milligram also OD, combined with one integrase inhibitor, that's dolutegravir, which is 50 milligram OD. Now, this combination of medication is used in pregnancy. It's used in pregnancy, but it's contraindicated in HLA B5701 positive. Okay, and then why is it contraindicated? Because it causes hypersensitivity reaction, but that is one of the most common medication given to pregnant women. We have another combination. This time around is lamivudine and then dolutegravir. And this medication also comes in a single combined drug, Ovato, which is taken as one tablet a day. This combination of medication cannot be given to a B viral co-infection. So if patient has HIV and have hepatitis B virus, you can't give this combination. Why? Because there is no medication in this tool that can take care of the hepatitis B virus. Okay, so once patient comes to you and has HIV and has hepatitis B virus, you cannot give this combination. But if it is HIV alone, lamivudine and dolutegravir can be given to the patient. Now, post-exposure prophylaxis. Let's look at post-exposure prophylaxis. One, someone has been exposed to the virus. What happens? A health worker has been injected, incidentally got injected with a syringe of an infected person. You screen this patient, and the patient has HIV and is already on medication. That is post-exposure. So once this happens, you can give this combination of medication, tenofovir, emtricitabine, which is the backbone, okay, nucleoside reverse transcriptase inhibitors, plus one protease inhibitor, that is raltegravir, 400 milligram. And this combination of medication is given to the patient for 4 weeks. That's a month, and should be given within 72 hours of exposure. So once someone is exposed to the virus and then patient is tested and is positive, then you can go for this combination of medication given to the affected patient for a month. But this should be done within 72 hours. So that is post-exposure prophylaxis. Now, coming to pre-exposure prophylaxis. This is indicated in high-risk population. Men who have sex with men, serodiscordant partners, where a patient, one relative, one partner is positive and the other is negative. That is what we call serodiscordant partners. So one partner is positive, the other is negative. Men who have sex with men, STI, IV drug users, and then inconsistent condom use. These people can be categorized under high risk population, and such people can go for there and then emtricitabine. So this time we are giving only nucleoside reverse transcriptase inhibitors, okay, for pre-exposure post-exposure prophylaxis, where you give the 2 backbone medication plus a protease inhibitor. So that's the difference here. HIV in pregnancy. What happens? Now, what we do here is that we give zidovudine. Like I said earlier in one of the medications, we are giving zidovudine plus 2 other antiretroviral medications. Okay, and then efavirenz is the only medication that is contraindicated in pregnancy. Forces. When you are asked which medication is contraindicated, always look out for efavirenz. If it is part of the MCQs, that is the correct answer. That is the only medication that is contraindicated in pregnancy. And then we must always cancel HIV positive breastfeeding mothers to avoid breastfeeding. Why? Because the virus can be transmitted to the infant during breastfeeding, which we said in our earlier slides during the mode of transmission. So let's take note of efavirenz. It's contraindicated in pregnancy. Now, prophylaxis and then other opportunistic infections that occur in HIV. Now, when CD4 cell counts drop below 200, there is a risk of patients getting pneumocystic pneumonia. And how do we treat that prophylaxis? We give first medication given is trimethoprim sulfametazole. Okay, you give trimethoprim sulfametazole to patients who have pneumocystic pneumonia. If the patient is allergic to sulfur-containing medication, then you want to give oral dapsone for a patient who is allergic to sulfur-containing medication. Now, if the patient has G6PD, then you always have to go for oral atorvastatin for G6PD patients. So once patient comes with pneumocystic pneumonia, which is an opportunistic infection, then you want to go for this medication for specific people. Also, as the CD4 cell count drop to 150 or less than 150, patient is at risk of histoplasmosis, which is a fungal infection. So you go in for itraconazole. And then once CD4 cell count drop to less than 100, patient is at risk of esophageal candidiasis, cryptococcal meningitis, cerebral toxoplasmosis. So cerebral toxoplasmosis, you are giving trimethoprim sulfametazole, but this time when you give double strength, okay, double strength. And then for esophageal candidiasis, you can go in for fluconazole. All right. Now, as the CD4 cell count drop further to less than 50, then the patient is at risk of disseminated or the cytomegalovirus, which can be rhinitis or colitis. So once there's disseminated MAC, you give high dose of azithromycin, 1,200 milligram daily per week, or you give clarithromycin. But with cytomegalovirus, whether rhinitis or colitis, you can give oral ganciclovir, that's 3,000 milligram OD for a day for 2 weeks, or oral aciclovir, 800 milligram OD per day for 2 weeks. So these are the prophylaxis for these opportunistic infections, and we need to look out for them once a patient presents to us with HIV, and then we realize that the CD4 cell counts are dropping. We should always look out for these opportunistic infections, and then these are the various medications that can be used to tackle these opportunistic infections. Now, once patient is infected with HIV, you want to monitor like we do for all patients. You want to monitor viral infection, bacterial infection. You want to monitor the patient and see if patient is responding very well to your medication. So what do we do? Monitoring of HIV, all you do is do the HIV RNA viral load. So once you do the HIV RNA viral load, what are you looking for? You are looking for undetectable viremia, where there will be no virus in the patient's blood. And then another thing you also look for is an increase in the CD4 cell count. Okay, so monitoring, you are doing the RNA viral load of the HIV, you are looking for viremia, undetectable viremia, or less or low or no virus at all in the blood. And then you're also looking out for a rise in the CD4 cell count of the patients. Some important things I want us to know in respect to the management of HIV. When patients have renal impairment, we need to avoid tenofovir. Patients with renal impairment, we need to avoid tenofovir. And in this case, you go in for alafenamide, okay, 25 milligram daily. And patients with co-infection with hepatitis B, you go in for tenofovir and tricitabine and then lamivudine. And then for pregnant women, always go in for zidovudine. Okay, and remember, equivalence is contraindicated in pregnancy. Complications of HIV, we have mentioned some of them. Patients usually have tuberculosis, cryptococcal meningitis, lymphomas, Kaposi sarcoma, neurological complication, candidiasis. It can be oral candidiasis or esophageal candidiasis. So basically, these are some of the complications HIV patients may present to us with. Thank you very much. And these are my references.
Excellent, excellent. Thank you so much, Dr. Opong, for a great job done. Within 45 minutes, we'll be able to do this. So participants, the floor is open. If you have any question, comment, addition, or subtraction, kindly electronically raise up your hand. I will mute you to go ahead. So whilst we wait for hands to go up, I see two questions in the chat box. I will quickly read those two and then you can answer. Raphael is asking, is HIV an oncogenic virus? And then let me just take the second one so that you can take those two. Oxygen says, how long does it take for HIV to manifest or tested positive after exposure through any of the routes? So those are the two, Dr. Point, if you want to take that. HIV oncogenicity and then from the incubation period.
Okay, so from my reading, I did not come across HIV being an oncogenic virus, but then there may be other opportunistic infections which can be oncogenic. But HIV itself is not an oncogenic virus.
Yeah, so fantastic, absolutely. So it's not itself oncogenic, but like you mentioned, typically HIV will render the patients that are infected are predisposed to developing those malignancies, especially those that are transmitted by oncogenicity, which are considered as oncogenic viruses, like the human T-cell lymphocytic virus and all of that. So HIV itself is not oncogenic if it's in the MCQs, just like Dr. Pon said. And then the second one, I think the participant was asking
about the second one with the incubation period. Sorry, I did not put that in the slide, but then the incubation period is usually between 1 to 3 months. That is what I have seen in some books. And then, but patients, of course, may come with flu-like symptoms within 2 to 4 weeks, which initially I said you may not think it is HIV because there are other viruses that can come with those non-specific symptoms. But then the incubation period should be between 1 to 3 months.
Absolutely. Very. So there's someone who is up. Yeah, also Brony, please, I've asked you to unmute yourself if you could go ahead with your comment. Thank you. Please unmute yourself.
Thank you very much, Dr. Pong. Please, my question is with regards to breastfeeding, HIV mothers breastfeeding their babies. In Ghana, is it outrightly cancelled that breastfeeding mothers who have HIV are not supposed to breastfeed, because there are places where HIV breastfeeding mothers breastfeed their babies, and their babies are put on antiretrovirals. Also, there's another question with regards to the quick, I think with the testing, I think there was a diagram you showed, and it was with, yes, this one, first response and oral quick. They're reactive to the first response and oral quick, but non-reactive to the SD bioline. During that point where you are waiting for the 14 days, do you start them on antiretrovirals, or you just want to test positive for AIDS so that you record in the data? Can they be started before they be retest so that you can get a negative or something? That was what was going through my mind. If you could clarify that for me. Thank you very much.
Yes, so thank you very much, Doc, for your question. So the very first question, in Ghana, we allow, it's debatable, but then mothers are allowed to breastfeed their children while the children are put on ARTs, okay? But elsewhere, children and mothers who are positive to HIV are prevented from breastfeeding their babies, okay? Because like I said, it's a mode of transmission, or it's a route of transmission for the child to get a virus. But in Ghana, children are put on medication. Not everyone is put on medication. Children can be put on medication, and whilst the mother breastfeed the child, okay? And then your second question with regard to the testing of pregnant women and the general public in Ghana, like I said, if the first response and then oral quick comes out positive, but non-reactive to the SD bioline, please, you don't start the treatment, because here Ghana Health Service is saying that all the three needs to be positive to classify the patient as HIV positive. So once first response and then oral quick are positive, and then the SD bioline is negative, you don't start the medication. You wait for the 14 days grace period to retest the patients. I don't know if I have been able to answer you all. Boss Dominic, you can come in, please.
Yeah, so I just wanted to add in for the breastfeeding. The reason is that most of we are in a third world country where lots of people cannot afford. So in terms of formula feeding, now the thing is that the terrible thing to do to an HIV exposed, as the term should be, baby, is to do what we call mixed feeding, i.e., doing infant formula and then doing breastfeeding with it. The risk of transmission is high with that, with mixed feeding, as compared to doing just the breastfeeding. So now, if you put a mother who really you are not sure of the income to be able to buy formula feeds, mind you, those are really expensive stuff like SMA, like NAN1, and those who probably may be used to those one after meal and all of that, really expensive stuff. And so the mother may initially start off with that, and then with time she starts supplementing with the breastfeed, and so that makes it quite difficult, and the risk of transmission then increases. So the rule of thumb is that those who cannot exclusively do the infant feeding, a better way as compared to the mixed feeding is to do the exclusive breastfeeding with the baby being put on the zidovudine and the mom as well being on treatment. So that reduces the risk of transmission. And of course, in our environment, most people will not be able to afford that as well. So that's just the addition I wanted to bring in. I think also Brony Yao, your hand is still up. You could unmute yourself if you have another question, unless it's a legacy hand.
No, please. It's a follow-up. I think the question I asked for the second one didn't come clearly. I was just wondering if you could start a prophylaxis. I know prophylaxis you start it in 3 days, but if they're reactive to first response, oral quick, and is reactive, but non-bioline is non-reactive. Could you start a prophylaxis?
Yes, absolutely, absolutely. So what he was talking about is with treatment of HIV,
Okay.
post-exposure prophylaxis. You don't take chances. Once the patient has been confirmed to be positive, you are not even why will you wait to have the infection done and then you go ahead and do treatment? That would be, for lack of a better word, criminal. Because once it's there, you are going to go ahead and give your PEP, post-exposure prophylaxis. So that's entirely different from the treatment we're talking about, like
Yes.
Yeah.
Yes, please let me come in. I think I wasn't talking about the post-exposure prophylaxis. I'm talking about with this diagram. If you react to the first response and oral quick and non-bioline, can you do prophylaxis?
Yes. But
Okay.
that is not equal to treatment. That's just what I'm trying to say.
Okay, all right.
So that forms part of like a post-exposure prophylaxis sort of.
Okay, all right.
Exactly.
But here's the
But
case,
that,
you see, the 72 hours you may not know if 72 hours or 72 hours has expired. I mean,
Yep. So it still comes to the point I was talking about that, you see, we say guidelines are made to guide the people. We don't take guidelines verbatim. What benefit is it to you having to wait and then the person tests at the end of it as positive? So if really the exposure is there from the history and all of that is taken, and this is someone who has probably had those initial tests positive, you can go ahead with the prophylaxis. If it is a full-blown infection, you have it and then you have the treatment done. But if the prophylaxis is given, assuming it's an acute and we don't know if it's within the 72 hours or even later than that, it causes no harm at all. Ethics says that err on the side of caution rather than having to wait to have the book satisfied and the patient dead.
All right. Thank you very much, boss, for your input.
Fantastic. So let's proceed. I'm sure he's fine. His hand is down now. So Oxygen, please go ahead. I've asked you to unmute yourself.
Yes. Hello.
Yes,
Good
sir.
afternoon. My issue has to do with disclosure of status to close contacts or close relatives. Especially sometimes in the case you have a patient on the ward, and then the person who is immediately taking care of that patient, sometimes discarding their fluid, washing of their clothes and stuff. You see that they are at risk. But per the Ghana AIDS Commission protocol, they are saying that we should disclose to any other, except maybe the patient agrees or decides to do that disclosure to the relative themselves. So I see that a lot of the times those relatives are at risk. Is there any revision on this protocol or is still the same thing? That is my question.
All right. Thank you, Oxygen. Dr. Obom, do you want to take that?
Yes. Thank you very much, boss Dominic. But these are the protocols, okay? And disclosing a patient's identity of being positive to HIV to his or her relatives is dicey, okay? And then Ghana Health Service or Ghana AIDS Commission has laid down rules for this, and you need to actually counsel the patient for the patient to understand very well that disclose my identity to my relatives. Other than that, it's risky. We are putting relatives at risk, but these are the laid down procedure because of ethical reasons, and then the issue of patients' relatives suing health facilities. It's always advisable to play on the side of caution, okay, to make sure that your patients are always informed and they give you the go ahead to do that. Other than that, for me personally, I think that you do not have the right to disclose the patient's identity to relatives. Dr. Dominic, I don't know if you have an additional input.
Yes. So that's very true. Medical ethics again talks about patient confidentiality, and the rules are as stated. The only caveat is or the part of it with regards to HIV and infectious disease is that there's some provision in the law that allows you to be able to, on the grounds of the person being a public health threat, be able to have that disclosure done. But there are strict guidelines with it. So that strict guideline says that you need to see the district magistrate, the judge, and make a formal application that, look, this person is a threat to the spouse, and I have counseled him appropriately. I've gotten experts to counsel him. Mind you, we are not jack of all. So if you are a doctor, you are not a clinical psychologist, and you are not the appropriate person to do that. So you invite the hospital counselor or clinical psychologist trained and certified to do this, because they have ways of doing it that the person can then find a way to disclose it to the spouse. If you do this counseling and the person does not, and is seen as a threat either to the spouse or to the public, then you obtain that permit from the district magistrate court, and then with that permit, you can go ahead and disclose the status to the spouse. This is from what the law says worldwide, both in like the UK practice, and that is what we have probably taken up by way of ethics. So that's just for knowledge as well. But you cannot, like Dr. Paul mentioned, patient confidentiality. You can't just go ahead and say that, okay, since you are pregnant, I need to tell your wife. No, it's usually through the patients. And in actual fact, in treatment of HIV, there are those that we call monitors. So the patient needs to usually identify somebody that he can trust and have this disclosure done, so that that person can sort of help him, guide him, encourage him, and be with him in the treatment. So I think that would help. Nana, I think you are next. Your hand is up. Kindly unmute. I think Nana, that's Dr. Ado. Hi, Dr. Ado.
Oh, hello, Sinakatiba.
Oh, fantastic. It's good that we have a lawyer to help us with the medical ethics.
Thanks so much. Thanks so much, Doc. That's a very interesting topic.
Great.
And
Yeah.
well done, Kwabna, for the exposition. I didn't get the latter part of your submission you just made, Dominic, very well. But yes, the issue of disclosing to relatives who are at risk and also the spouses have really been an ethical matter and has been debated on a lot of fronts. I will just seize this opportunity to just mention a few. Yes, there's confidentiality. You can't disclose the HIV status of a person, just anybody like that. Even to the relative or even the spouse, you cannot do so unless you have the consent of the patient. So the quick question that it typically follows is if he's putting this person at a risk. Let me start with the relative who will be washing the clothes, sometimes stained with blood and other things. Dr. Katiba, if you tell a woman to take care of her HIV relative, child, anything like that, and her hands are exposed to all the risk, and she's not told anything at all regarding what she's dealing with, and she contracts it, the system has been negligent. The hospital or the doctor involved has been very negligent because you have withheld certain vital information that would have prevented her, if she had been informed, from getting the infection. But would that not also be a breach of confidentiality? It's a yes and no. And let me explain the fine line there. Dr. Pong, the simple solution to this is that, and in law, what we say is that you disclose what is minimally necessary. It doesn't have to be everything. The woman is exposed. She needs to be told something that there is an infection here. It's difficult to treat. Therefore, we do not want you to wash with your bare hands. We do not want you to be exposed. you may use gloves, you may use that, you may take this from, without necessarily mentioning the specific diagnosis. And that's what we expect health workers to do. Let the relative be aware of the dangers. There is an infection you are dealing with. We are treating an infection. And therefore, take these precautions, take those precautions, do this, do that. You need to help her in that respect, but without necessarily mentioning the specific diagnosis. Once you do that, you are apt within the law, and no such suits can come against you, or you may not be found guilty on that. You caution the person and you took steps to ensure the safety of that person without necessarily disclosing the diagnosis. That's if the patient did not agree that you should go ahead and make the disclosure. Then the second thing has to do with the spouses. And I think, Atiba, you touched a bit on the law regarding these disclosures. It's on the, in fact, it's not even in our mainstream health laws. It's actually at the Domestic Violence Act. The very first section that defines domestic violence at the BI continue to say any person with HIV, before you have sex with another person, you should disclose your status. Now, we've criticized this law that it is unpractical and it won't happen. People won't do it. So at a point, we're trying to push for an amendment. But what we thought was, and I've had some engagement with Dr. Ankobi and Co. on this, the midline we took was that, look, not every person with HIV is necessarily a risk to another person. And therefore, like Upon said, if he's taking the medications, the antiretrovirals, and the viral level has gone so down, CD4 count is good, and all of those precautions have been taken, the person may not be a risk to even a person he has sex with, even with or even without a condom. CD4 count can drop so low. Sorry, it can be so good. Viral load can drop so low to undetectable levels. And people have, achieved these. And therefore, it is said that when the risk is not there, then the disclosure may not be absolutely necessary. So the mere fact that a person has HIV or is positive does not mean, hey, take the gongon or go straight to the judge that somebody is here is a risk to the spouse. You have decided not to disclose and therefore issue orders here and there. It won't work. It won't work. In fact, there's a whole CPD coming. We are going to address these matters in detail because I remember a case where a doctor was HIV positive. The staff at the hospital protested that he should not do any surgical cases again. This went to court, and the judgment of the court was very interesting, that the doctor was allowed to proceed to do the surgeries because the precautions had been taken, and the risk, according to Judge Rose, or the risk of him giving the infection to any patient was extremely low. Yes, we are aware sometimes during even cesarean sections, our gloves get torn. We prick ourselves here and there. But putting all of that together in totality and in recognition of the fact that he was on the antiretroviral drugs and all that, the judge said he could go ahead and operate just like any other normal doctor. Some nurses have been found like that, and the law's position was unchanged. So we do the disclosure only when the patient has refused to take the medications. And I'm sad to say I've had a patient like that. He got the medics not to inform the spouse of her status. It was a lady, her status to the husband. So she was taking the drugs and all that. So things were fine. The CD count was good. The viral load was very, very low. And things proceeded fine. But at a point, she had a fight with the nurses during one clinical attendance. So she said, then I won't step here again. The nurse did not do any follow-up, and it is at such cases, at this point, where she decided not to take the drug, that's when you may take those extraordinary steps, like Dr. Katiba mentioned, where you may then seek some declaration that then, at this point, she has become a risk to the household. But she decided not to come. Nobody did the follow-up. The viral load probably shot up. CD4 count probably went low. And within this period, he infected the man. The man had a case to sue the hospital for the non-follow-up and for not giving him any information. But normally when it happens like this and we threaten that if he does not take the drug, we will disclose, normally they come around. and they take the drugs, or sometimes we refer them to other facilities where they don't have any conflict with the health workers, and then they proceed so mostly our interest, to conclude, is on them, encouraging them to take their medications so we can keep the viral loads low, and so that we can keep them healthy, so that we don't disrupt their family life. But where they do not cooperate, then we are forced to take these extraordinary steps to bring them on board. Thanks so much, Senior, for the opportunity.
Excellent. Thanks so much for the great insights. Good to always have you around to provide the legal basis and recommendations. Thanks a lot. Jennifer, kindly unmute and then have a go. Hi, Jennifer. I've asked you to unmute yourself.
Thank you very much, Doc. Please, my question is on the first response and the oral quick and the SD bioline. Why you have only the first response and the oral quick, and you don't have the SD bioline? But you test the person and both are positive. That's the first response and the oral quick. But because you don't have the SD bioline, you couldn't do that one to confirm. Can you declare the person positive? Because initially, I think the SD bioline was just introduced recently. First, we used only the two to confirm the person positive. So can you still go ahead since you don't have the SD bioline? Thank you.
Great. Thank you. Dr. Pong, will you take that?
Yes. Jennifer, thank you very much for your question. Well, so based on what our association or the body of health in Ghana has come out to say that this is the lay down procedure, I think only oral quick and then first response, or first response and oral quick being positive, you cannot declare the patient as HIV positive unless you have done the SD bioline. Okay. But on the other side, you see, when first response is reactive, but the oral quick is non-reactive, you also have the chance to repeat both of these investigations again, but you do them sequentially. Okay, then when it comes out to be reactive for the first response, and then oral quick confirmed with SD bioline. Okay, you have to confirm with oral quick and SD bioline. But where you have only the two being positive, you can declare the patients as HIV positive. Dr. Dominic.
Yeah, great. Sorry, my network dropped off. So there's no hand up. We'll probably check in the chat box and then see if there are any more questions there. So I think we've probably answered most. Okay, so there's one which says, please, can we see the references again? I think somebody wants to have a look at your references for further
Yes.
reading.
So I use UpToDate, Merck manual, SlideShare, and then lecture notes from WACAS, and then manual of MSD.
Great. Just to announce that this webinar is recorded as well. So if you want to have a look at the slides at your own pace, you can check on our YouTube channel. I'll post the link in the chat box. And then you can have the slides, transcription of the slides, and the video recording of this webinar. So that should answer Al Hassan Zainab's question about where you can get the slides and recording. And then I don't know if Jennifer has asked this before, but she put in that what ARVs are given to the babies and what test is done for the exposed babies. So Dr. Point, if you want to take those two.
Yeah, so for infants, like I said, you need to do the HIV-1 or HIV-1 RNA testing. So you do the RNA testing, either polymerase chain reaction or the nucleic acid amplification test. This is the test that can be used to confirm HIV in babies. And then, of course, the treatment for HIV babies is not different from what we use for adults. Okay, I didn't come across any different medication, but it's the same medication but different strengths. Thank you.
Great. So just to announce that I've put in the social media pages for the slides, the recording, and then the Facebook and LinkedIn account so that you know what presentations are up next. Thank you. I think we've gone way beyond the hour, and I don't see any hand up. Sorry, we can't take a lot of the other messages on the platform. I'll probably just read a couple of the comments that are in there, and then we call it a day. This has been an excellent presentation. Thank you, Dr. Opong. I think there's one from Hafizu, says, between the time of detection of infection until what we are able to achieve low viral load levels, how do you ensure spouses of HIV patients are protected from getting infected without having them to inform them about the status of their spouses? So, like we earlier discussed, one of the bigger things is to achieve an undetectable viral load, and that reduces the risk. So, it's the compliance that is key, very key. And definitely, we usually encourage them to have a disclosure to a third person who serve as the monitor. Most likely and most usually, it is usually the spouse who serves this purpose. There are a couple of people who are positive, but their spouses are negative. What they call is it discordant couples or so. So Raymond also puts in that Dr. Bond, this is a great presentation. You have simplified the complex topic. Well done, boss. For his contribution, having counseling prior to testing is very key in the workup for patients we are investigating for HIV. The consolidated regime for HIV care in Ghana has a comprehensive guideline on counseling, and we all need to look it up and refresh our memory. Then his question is, with the news that there will be a cut in funding from the USA, will it affect HIV treatment? What's the fate of those patients? This I know is for policymakers. Absolutely. So it's good that put that in. I was hoping Dr. Kambon, who is the CEO of the Ghana AIDS Commission, would have joined. I'm sure he would have given some insights into it. But what I can say is what our political leaders have put up and we have all seen. The president has asked the Minister of Finance to find funding for that gap created by the USAID. I think it's about 17 million US dollars. As to where they'll find it, we don't know, but that's what the commitment is from the government. So hopefully we don't have to battle having people not being on their medications. Thanks, Dr. Raymond, for the excellent contribution. So on behalf of everyone, Dr. Opong, we want to say we are grateful for making time to present to us today and making this really complex topic very simple for everybody's understanding. We are grateful and God bless you. And we thank all the participants who were able to join us today. And like you see in the chat box, the YouTube link is there. If you click on it, you subscribe, you have this recording and all the other recordings. Dr. Boy, any closing remarks before we
Yes, I want to thank Dr. Dominic and then the Ghana Medical Help Team for giving me this great opportunity to enlighten everybody about HIV. It's a very broad topic, but by God's grace, I was able to break it down into the minimum for everybody to understand. Thank you also, all participants, for listening to me. I'm grateful. God bless.
Fantastic. Thank you so much. And thanks to all the participants. Also, by way of information, next week, the legendary Dr. Abednego Ator will be leading us with a presentation on hepatitis, chronic viral hepatitis B, hepatitis C. So make a date. It's quite prevalent in our country. We are classified as endemic for hepatitis B, and there's even hyperendemicity in the northern parts of Ghana. Unfortunately, people still suffer from this disease, which should have been off, and even we are getting a lot of mortalities from it. Diseases that have cure, like hepatitis C, should be a thing of the past. So make a date. Let's get the updates. Same time next week. Same link, same login account, same password, and we'll be there. Thanks a lot for joining us. God bless all of us and have a great day. Bye bye.